Hello, my name is Ricardo Romiti. I am a dermatologist at the University of São Paulo in Brazil, and I'm a board member of the IPC. Today we'll be discussing the risk of infections during both conventional and biologic treatment in psoriasis patients. These are my conflicts of interest. And this is the Hospital das Clínicas in São Paulo, where I work in Brazil. Now, first, is psoriasis itself as a disease associated with an increased risk of infection? We know that when we talk about the more severe spectrum of psoriasis, patients with generalized pustular or erythrodermic psoriasis, the risk of infections is enhanced. But when talking about plaque psoriasis, data is extremely poor. Patients with psoriasis generally have a lower risk of superficial cutaneous infections, especially when compared to atopic dermatitis patients, and this is generally due to the enhanced expression of antimicrobial protein genes. A large Dutch study evaluating over 25,000 patients, followed for a period of 6 years, showed that there was an increased risk of infections requiring hospitalizations for psoriasis patients when compared to the general population. The magnitude of risks for these patients was associated to the severity of the disorders and not with the recent systemic medications. And what about the risk of infections when we compare conventional to biologic treatment? Databases from two large US health insurances evaluating over 107,000 patients between 2003 and 2015 showed an overall decreased rate of serious infections of patients under apremilast, etanercept, and ustekinumab when compared to methotrexate. No different rate of overinfections was observed among users of acitretin, adalimumab, and infliximab when compared to methotrexate. When we look at registries, we have very consistent data from all around the world. These are the informations we have from the SOLAR study, a very large intercontinental registry, following until 2013, 11,466 patients, and showing that infliximab has the highest risk of cumulative incidence of serious infections, followed by adalimumab, always when compared to methotrexate. Ustekinumab did not increase the risk of serious infections when compared to non-biologic treatments, and pneumonia and cellulitis were among the most common causes of serious infections in both biologic and non-biologic groups of patients. Here, data from the British Association of Dermatologists showing no significant increases in the risk of serious infections for etanercept, adalimumab, and ustekinumab when compared with non-biologic systemic treatments or methotrexate only. Here, data from the Spanish registry following 2,153 patients until the year of 2015, showing that acitretin had a significant lower risk of infections when compared to methotrexate. Cyclosporin had the highest risk of infection when compared also to methotrexate. Anti-TNF drugs had the highest risk of overall infections, and within this group, infliximab standing at first point. Ustekinumab had the lowest risk of infections when comparing these drugs. And during the treatment with conventional and biologic therapies, when do infections tend to occur most frequently? Here, data from the British Society of Rheumatology Registry comparing anti-TNF drugs with DMARDs, showing that with anti-TNFs, the risk of serious infections tend to be higher during the initial period of treatment. When compared to conventional DMARD therapies, this risk tends to happen after 400 to 500 days of therapy. Emphasizing this, we also have data from the Swedish Biologic Registry showing that the highest risk of hospitalization due to infection with anti-TNF drugs tends to happen during the first year of treatment when compared to the second and third year of therapy. But when we look at the interleukin blockers, there doesn't seem to be a difference when we look at the time periods. Here, data from the ustekinumab study following patients for up to 5 years, and we see that the risk of infection is low and relatively stable during the first 5 years of therapy. Here, data from the neuro anti-IL-23 blockers for guselkumab, for example, also showing that when we look for the short period or longer periods of treatment, the risk of infections is low and stable during the first years of therapy. Concerning conventional therapies, we have this publication from the French insurance database comparing different traditional therapies, showing that with cyclosporine, the mean time for the first infectious event tends to be much lower than when compared to the other traditional therapies, such as methotrexate, phototherapy, and even acitretin. Now, talking specifically about tuberculosis, we know that this type of infection is a big issue when we talk about biologic treatments, specifically anti-TNF therapies. So what is the risk? Tuberculosis is a big concern when we talk about mortality among infectious diseases. Here presenting the global tuberculosis report with incidence rates of TB all around the world, showing that at specific countries, especially in Asia, Africa, but also Latin America, the incidence of tuberculosis are still extremely high. We know that TNF has an important role in maintaining the TB granuloma stable, and once we initiate anti-TNF therapy, there is a high risk for breakdown of this granuloma. We know that within the general population with latent tuberculosis, the risk of reactivation during life may be between 5 and 10%, but once we start anti-TNF therapy, this risk may be up to 9 times higher. Here illustrating some patients from our department. Here a case of peritoneal tuberculosis during anti-TNF therapy. Another case of ocular TB, an extremely rare manifestation of tuberculosis during biologic treatment. And here a unique case of tuberculosis affecting the tongue, the only manifestation of reactivation of tuberculosis during anti-TNF therapy in this patient. We know that adequate screening for tuberculosis is mandatory before we start biologic treatment, so realizing PPD or quantiferon tests, the X-ray, and checking for the personal history and the familiar history of contact to tuberculosis is essential before we start treatment, so as to diagnose latent tuberculosis, and if present, start the adequate chemoprophylaxis in psoriasis patients. We know that once the screening for tuberculosis was initiated all around the world before starting anti-TNF drugs, the rate of reactivation of tuberculosis lowered considerably. Here showing data for infliximab patients, and here showing similar data for adalimumab patients. When we talk about anti-interleukin biologics, we know that this risk is extremely low. Data for ustekinumab patients showing no risk of reactivation of tuberculosis. Data with the anti-IL-17 drugs also showing no evidence of reactivation of tuberculosis. And here, interesting data from the anti-IL-23 blockers, specifically risankizumab, showing an absence of reactivation of tuberculosis during pivotal trials, and even for a specific group of patients with a diagnosis of latent tuberculosis and did not undergo chemoprophylaxis, and no cases of reactivation of tuberculosis in these groups. And to finalize, we cannot talk about infections without mentioning our pandemic, and here just showing the statements of the IPC concerning coronavirus, that there's really not a reason nowadays to stop biologic treatment during the pandemic. Just really in cases of active infection, we should stop biologic treatment. Thank you very much for your attention.